So, in 1901, this fella here, Dr. A, gets a new patient, Mrs. D. And Mrs. D is in her early 50s and has had problems with memory for quite some time and is psychotic. She's imagining things and is delusional. Dr. A, Alois Alzheimer, didn't know what was wrong with Mrs. D and didn't have a clue how to help her. 5 years later, 1906, Mrs. D dies of her disease. And Dr. Alzheimer was so interested in what was wrong with her that at autopsy, he did a stain of her brain using the technology of the time, which was photographic imagery. So he did it like he would develop a photograph. And what he found were these clumps of stuff up here, these globs of things, which he called plaques. And these kind of gnarly pieces here, which he called tangles. A couple of years later, a friend of his, a psychiatrist in Germany, where he was from, named the disease after him and called it Alzheimer's disease. Now, the sad truth about Alzheimer's disease, next. The sad truth about Alzheimer's disease is this. If Mrs. D had been seen by Dr. Alzheimer today, 115 years later, there's very little more that can be done for her today to treat, to slow down her disease, or to prevent its inevitable outcome, which is death. So that's the bad news about it. What I'm here to do in the next 40 minutes is kind of tell you about the good news, the hope for the future in development of Alzheimer's disease. And I realize that some of you here are caregivers, some are professionals. So to make sure we're all on the same page, I'm going to kind of start at the beginning, describe this disease, what we think causes it, and some of the new information about what's going on to help it in the future. And what we're going to talk about are these things: the burden of the disease, the difference between the mental effects of just normal aging and dementia, how we make the diagnosis of Alzheimer's disease. We'll talk about present-day treatments, and you know I put that in quotes because there's some difficulty with our present treatments. And we'll talk about some other things, if you're interested, that are pretty heavily in the news these days. We'll talk about the brain changes, what we actually think causes the changes of Alzheimer's disease. And we'll talk about research, future treatment, what that's all about. And finally, we'll talk about how you can be of help in terms of future research and treatment of this disease. This disease, as you know, is a very common disease, and it's increasing. It's very costly, and it's increasing. And it's not totally appreciated for the problem it really is. Those caregivers understand that, but maybe others don't. It's common. 5 million Americans right now suffer from this disease, 350,000 in Texas, and a new case presents about every minute. About every minute. 1 in 9 of us, age 65 or older, and I'm in that number, 1 out of 9 of us suffer from this disease. And when you hit age 85, that number jumps to 1 in 3. The numbers, and this is the scary part, the number of people with Alzheimer's disease will triple in the next 35 years. Why is that? Well, what's the biggest risk factor for Alzheimer's disease? Too many birthdays, right. Too many birthdays. And 10,000 baby boomers are turning age 65 every day, every single day. It's a costly disease. It costs $236 billion. That doesn't mean much to most of us, but it's twice as costly as heart disease or cancer. Maybe that'll put it into perspective. It takes up 1 out of every 5 Medicare dollars today, and remember, the number will triple. It's the 6th leading cause of death, and probably that's not real. Probably it's the 3rd leading cause of death. Why? Because we don't diagnose death from Alzheimer's disease generally. People die of something else, pneumonia or not being able to eat or whatever it is. It's very emotionally difficult. Forget the cost, the emotional difficulty for families and caregivers. Those of you who are here know, if we could just delay entry into nursing homes by 5 years, we can cut the cost of this disease in half. Cancer and heart disease are responsible for 550,000 deaths each per year. Alzheimer's disease is 500,000. And you might say, well, oh, wise one, you said this was a big problem. Look, these are the big problems. But the number of Alzheimer's deaths will triple in the next 30 years, whereas the number of deaths from heart disease and cancer and AIDS are all going down. The number of deaths from this disease are going up, and it's the only one of the top 10 causes of death that can't be prevented, cured, or even slowed down. And yet it's not being recognized by the government, or for that matter, those people who are not directly related to it in one way or the other, as the big problem it really is. I'll tell you about that in a minute. So let me tell you about this patient, Mrs. H. So Mrs. H and her husband, who are friends of mine, by the way, are preparing to go to a wedding in Houston. They live in San Antonio. They're preparing to go to a wedding of their niece, Helen. And they're talking about how much fun it's going to be and how they're going to meet all the family members and how many people they're going to get to see. And they're overjoyed about going. Mrs. H is still functioning well. She's driving. She's doing volunteer work. She's doing her housework. She's become a little more forgetful. But right after the discussion, she looks at her husband, who says, you know, we're so lucky to be having been invited and going to this wedding. And she says, wedding? Who's getting married? What's going on with this lady? Is she just showing signs of normal aging? Who votes for that? Does she have dementia? Who votes for that? How about this one? Is it something in between normal aging, memory, and dementia? We'll give you the answer in a minute. Let's start with what is memory loss from normal aging? I mean, when I forget where my car is in the parking lot at HEB, is that a sign of dementia? Well, could be. When I forget the word that I've given in the same talk 100 times, and doggone, I can't think of it. Is that normal aging or what? And the answer is, it certainly can be. Our thinking processes peak in our 20s and early 30s, and it's all downhill from there. The speed with which we process information slows down over time. So it takes a little longer for our brains to learn things. So when we can't recall the name of the guy in front of us that we've known for years, that may well be normal aging. So most of us show a decline in our thinking speed, and we may forget a little something, but we're functioning just fine otherwise. and that's normal aging. Or what's called subjective memory impairment. On testing, it doesn't show abnormal, and it doesn't get in the way of our day-to-day functioning. That's normal thinking. Memory loss is on a spectrum, and it goes all the way from normal age loss, normal memory loss due to aging. The next step is something called MCI, mild cognitive impairment. You're reading a lot about that now because it's in the news a lot. And the reason it's in the news is that's where the hope is for future preventative treatments. By the time people have developed full-blown Alzheimer's disease, it's too late probably for preventative treatment. So we're starting to find people at this stage, which means that there's an obvious objective difference in their thinking that we can measure on some testing, but it doesn't impair their functioning. They're still doing just fine in day-to-day life. And then what may come is the third phase called dementia. Mild cognitive impairment. So this is thinking loss, memory loss, which is obvious to others and to the person themselves, but it doesn't impair their functioning. Remember, I told you Mrs. H was still driving, still functioning, still doing her stuff. So what she was probably suffering from was mild cognitive impairment. If you have this, and you can pick it up on some testing, and this is one of the tests we use, I'm not suggesting you learn it, but it's one of the pen and paper tests called the MoCA, the Montreal Cognitive Assessment. A couple of others that we use for memory screens, one is called the Mini Mental Status Exam, MMSE, and then there's one that was designed at St. Louis University called the SLUMS. What a horrible name for a test. But if these show abnormalities that represent a difference from what most people of the same age are functioning, that can be an indicator of mild cognitive impairment. Dementia is the next phase. So dementia means brain failure due to degeneration of the brain that shows up as thinking decline, including memory problems. And here's the key, it's severe enough to impair day-to-day functioning. People can't function like they used to. They can't cook, they can't clean, they can't drive the car safely, and other things. But that's in a continuum. Some people are not so severe. Some people are more severe. So the question I'm usually asked is, what's the difference between dementia and Alzheimer's disease? So dementia is kind of an umbrella term that talks about how severe the problem is. It means that the problem is severe enough to show up on testing and it gets in the way of day-to-day functioning. It turns out that Alzheimer's disease is the most common form of dementia. 70% of all dementias are Alzheimer's. But there are other things that can cause dementia, including mini strokes in the head, blood vessel disease in the head, Parkinson's and Parkinson's disease-related issues, and the like. Alzheimer's disease is technically a neurodegenerative brain disease. It comes on slowly. If this dementia comes on quick, it's probably due to a stroke or some other condition. It's not due to Alzheimer's disease, which comes on gradually. The early hallmark is impaired ability to learn new information or to recall it. It impacts those 65 years of age and older. Remember Mrs. D? She was only 51 years of age. And it may interest you to know that for many years, it was thought that Alzheimer's disease was a disease of people in their 40s and 50s. If you got it in your 60s and 70s, that was called senile dementia. Until the mid-60s, when scientists autopsied a bunch of folks in their 60s who had developed this disease and found out how common it was and realized that this is Alzheimer's disease. And what we saw in Mrs. D was a very unusual type of Alzheimer's called early onset Alzheimer's. Those of you who have seen the film Alice, Still Alice, she suffered. She was in her 50s when she developed this unusual familial type of Alzheimer's. How do we recognize it? You got to have a problem with memory plus something else. And here are the other cognitive. Cognitive means thinking. Other cognitive problems. It may be difficulty with attention and focus. They can't pay attention on this, that, or the other, and used to read a lot and have trouble doing that. They can't learn new information. They can't communicate well. Their language is off. They want a pen and they say, can you bring me that, the thing you write with, and can't recall the language. There can be problems with visual perception. That's why people with dementia have trouble driving, because their visual perception is off. And reasoning and judgment, and something else called executive functioning. People with Alzheimer's can sometimes make toast and make an egg and get orange juice, but they can't make breakfast, because making breakfast implies you put a lot of things together. That's called executive function. These are the stages of Alzheimer's disease. I didn't put it there so you could read all of it, but it goes from 1 to 3, or some say 1 to 7. But the bottom line is it's a gradual declining disease, as you've heard from Rundi earlier today. The evaluation. Let me start with why it's a problem to even get the evaluation. The number one thing is stigma. When most of us think about Alzheimer's disease, even in the early stages, what do we think about? The guy drooling in the corner of the nursing home, inattentive, unable to function. And there's a lot of stigma to that. Before they get to that point, as Rundi has told you, there may be years. By the time somebody is diagnosed with Alzheimer's, they've usually had it about 6 years. And the life expectancy is somewhere in the 14, 15-year range. There's also fear, and there's also this covering thing. People in families cover for the Alzheimer's person so that other people don't know. Maybe they don't want to know either, and there's fear. So how do we diagnose it? Well, it starts with a physical and mental examination by a primary care doctor. And that's an important first step, or a neurologist. It's important to go there first to rule out other things it could be. I mean, there could be other causes of it. Or a common cause of what looks like dementia is medications. And you think about people today, they're taking 8 different medicines. Heck, they don't know what the mixture of that does. And some of those medicines worsens memory. So a physical exam, a medical evaluation, lab includes thyroid disease function, looking for that, because low thyroid hypothyroidism can cause what looks like dementia. Low vitamin B12 can cause what looks like dementia. Certain infections and other things can cause what looks like dementia. And then patients are usually referred for neuropsychological testing. At Clinical Trials of Texas, we have a neuropsychologist who does the testing. It generally takes a while, about an hour. Sometimes it takes even more than that. And what neuropsychological testing does is it gives objective evidence of how bad the memory problem really is. You know, when we see patients for our trials, we'll sometimes ask the patient, how you doing? Oh, I'm doing fine. And their pleasantries are all there. So it sounds like they're doing just fine, thank you, please, and very much. And then we ask the caretaker and find out how bad it is. Neuropsychological testing indicates that and what kind of problems there are. Some people have language, some visual spatial, some executive functioning, and that helps us. And then there's brain imaging. The most common brain imaging that we do is called MRI. Many of you have had an MRI on your hip or your knee or your shoulder. Well, we can do an MRI of the brain. But we don't do an MRI to diagnose Alzheimer's disease. We do it to rule out other causes of what looks like Alzheimer's disease. Things like a brain tumor, or things like too much pressure in the brain, or presence of many strokes that people, many MINI strokes that people have had. And then there's another kind of PET scanning, and I'll tell you about that in a little bit. What if the diagnosis exists? Heck, do we even want to make the diagnosis? There's nothing we can do about it. So what's the point of making the diagnosis anyhow? And if we do make the diagnosis, do we want to tell the family? Do we want to tell the patient? If a patient has cancer, what's the chances that the doctor has told them at the first visit they have cancer? The first visit, he knows it. It's 90%. If a person has Alzheimer's disease, what's the chances that the doctor has told them when the diagnosis is made? 45%. It's less than half. And it's done for a variety of reasons that doctors don't tell them. They don't want to hurt them. They don't want to shock them. They think they might get depressed, etc. So should we tell them? My belief is the answer is absolutely yes. One, we need to run other tests to make sure it is Alzheimer's disease, not something else that we could treat. We need to tell them so we can manage other diseases they might have that might make their symptoms worse. We need to tell them when it's early so they can make lifestyle changes that might make a difference in their life, diet, exercise, etc. And we need to tell them and families so we can start working on a plan for the future and develop a support system, just like you've heard about this morning. Support system for the patient, support system for the caregivers. Remember, in Still Alice, there was a period of time, even with her disease, which is very malignant and very fast going, when she knew what was going on. Those of you who have seen The Notebook, remember that once she got the diagnosis, she started working on The Notebook that her husband would read to her to try to bring her back later in life. And that was done at an early stage. Had she not been told, she wouldn't have known. And to begin drug treatment to help improve symptoms, I'll tell you about that in a second, and also to let people know about drug studies, which I think is the hope for many of the patients in the future. And if they know what the diagnosis is, if it's been properly made, when a new treatment does come along, they might be in line for it and able to use it. This just shows the genetic risk. It's a very busy slide, but basically, if you've got the early onset form, you've got a gene called the presenilin gene 1 or 2, and your chances of getting it are 50-50. Depending on which or both parents have it. Those with Down syndrome are more likely to develop Alzheimer's disease because it's found on a gene that has an extra copy in Alzheimer's. If you got a family member, I'm going to talk about that in just a second. But the bottom line is, it's not heavily genetic. Even if you've got it in your family, that's not a certainty that you will get it. So what are the risk factors? Well, there's this gene that many of you have heard about. It's called the ApoE4 gene. It's been a lot in the news. There's an ApoE2 and an ApoE3 and an ApoE4. The only one that's bad is the ApoE4. I happen to have the ApoE4 gene. And the ApoE4 gene is more prominent because it likely causes heart disease. But it's also associated with a greater risk of Alzheimer's. However, you can have the ApoE4 from both parents and a family history of Alzheimer's and still not develop it yourself. Diabetes puts people at higher risk. Depression puts people at higher risk. Black people have a more commonly developing of Alzheimer's disease, cardiovascular disease, and head injury. One of the concerns we have about these kids playing football and getting lots of concussions is whether those concussions in later life may predispose one to Alzheimer's. We don't know that for sure yet. The treatment, as we sit here today, education is number one. Getting a good support system is number two. I loved what Rundy said this morning, and I'd encourage you to read in the book some of the things you already know about Alzheimer's disease. Getting a good support system for yourself and early on for the patient. Medications that we have today. And I just put these up because some of your loved ones may be taking it, and so you may want to know about it. We believe one of the theories is Alzheimer's disease is due to too little of a brain juice called acetylcholine. So acetylcholine gets broken down by this enzyme in the brain, and if we block that enzyme that gets rid of acetylcholine, hopefully we can keep the acetylcholine there longer. So the acetylcholinesterase inhibitors are the drugs that are most commonly used. Aricept is the one that most of us know about. Exelon and Razidine are the other two. There's another mechanism of action drug. It's called an NMDA receptor antagonist, and the most common one of those is a drug called Namenda. And very recently, they developed a combination of Namenda and Aricept, and they call that Namzaric. So what do those drugs do? See this red line? That's the decrease in mental functioning of somebody with Alzheimer's disease. Over time, it gets worse and worse and goes down and down. So what happens if we give them Aricept or Namenda? Well, what happens is the symptoms may look a little better for a little while. And then they may stay looking better than the red line, but it's still going downhill. We can't change the slope of the disease. We can make the symptoms look not quite as severe. And that may be enough to keep somebody out of a care facility for a year or two, which isn't a bad thing, or keep them functioning for a year or two. How about these other things? Which of these things work? We see them in the news every day, so which of them work? Which of them work the best? If you had to choose only one, which would you use? I'll tell you about that later. So, what causes Alzheimer's disease? And the reality is we just don't know. Remember those plaques I showed you in Mrs. D's brain-stained autopsy result? Well, that is caused by a thing called the amyloid precursor protein. These plaques are called amyloid plaques. Beta amyloid plaques is the most common one. And in our bodies, we have this protein called the amyloid precursor protein. And what's supposed to happen is it's supposed to get sliced in half in the right place, and then your body gets rid of it. That's done by an enzyme called alpha secretase. But there are other enzymes that cut it, beta secretase and gamma secretase, and if those puppies cut it, they cut it wrong, and it kind of gloms together and forms these amyloid plaques. I'll tell you why I bothered to tell you about that. The other deal is, remember those kind of clumpy looking things I call tangles? Those are from a different kind of protein in the brain called tau, T-A-U. And those get in the way of the neurons in the brain. Let me show you this. I think it's kind of interesting and scary at the same time, but it explains why our research is going the way it is. So, here up here is the accumulation in the brain of beta amyloid. Remember, I told you that's what causes the plaques. Remember, there's a normal stage, there's a non-specific preclinical stage, and then there's that mild cognitive impairment. Here's where mild cognitive impairment starts. Dementia starts way over here. But looky here. This is the accumulation of beta amyloid in the brain. And look when it starts to accumulate. Way before mild cognitive impairment. Way before dementia. Maybe 10 to 20 years before somebody develops either mild cognitive impairment or dementia. And then this one here is tau. Now, tau starts to accumulate later, but by the time somebody gets to mild cognitive impairment, they've pretty much got all the beta amyloid in their brain they're going to get. And yet, their symptoms, their measurable symptoms, don't start till right there. Tau starts a little later, and then this is when brain structure starts going bad. And that doesn't happen till much later in the process. The point is, this process is starting much earlier in people's 40s or 50s. This is what happens as a result of the accumulation of all that stuff, kind of, sort of. This is an amyloid brain, this is a normal brain. You noticed how shrunken that brain is, indicating this is really a brain disease. It's not bad behavior. It's not wanting to be obstinate. There's something really going on in the brain. Right now, the tragedy is the only way we know for sure that it's Alzheimer's is at autopsy. And most people would suggest they don't want to wait that long to get the diagnosis. By the way, after what I told you before, remember, you get the physical and you get the lab work and you get the MRI and you get the psychological testing. What's the chances we know for sure it's Alzheimer's disease? And the answer is it's 85% sure. Now, that ain't bad, but in a disease as serious as Alzheimer's, we'd sure like to get it better than that. So, right now, the only surefire diagnosis is autopsy. So what we're looking for now is something called biomarkers. So a biomarker is something you can measure, either in the blood or in the brain or by x-rays or by other kinds of scans to indicate the presence of something that's much harder to diagnose. So these are some of the biomarkers that we have now. The hippocampus is where early memories are stored, and it starts to shrink early in Alzheimer's disease. And so on that MRI scan, we can see some of that shrinkage of the hippocampus. We can do a type of PET scan. A PET scan, by the way, is where we take something that gloms onto something that we want to study, and we put a radioactive tracer on it, so when it gloms on, In the scanner, we can pick up that radiation coming out and see in living color how much of something there is. Some of you know, if you've had a heart stress test, we use a scanner like this, which measures glucose, by the way. And then now, starting a number of years back, about 10 or so, we can actually measure this beta amyloid in the brain. That's how we know when it's starting to accumulate. I'll show you that in a minute. There are now measurement tools that allow us to measure tau functioning in the brain. And then we can look at genes. Some cool new stuff. There's an eye test. We now know that beta amyloid accumulates in the retina of the eye. And so instead of having to do a PET scan, which costs about $4,000 to $7,000, and by the way, insurance doesn't pay for it. They don't pay for it. Why? Because they say, look, you don't know what you're going to do with it anyhow, so why should we pay for it? But this eye test is much cheaper, and we were hoping to work on that. There's also a smell test that some of you have probably read about, and you can measure by smelling some of the changes in Alzheimer's. This is what a PET scan looks like. This is what an MRI, there's not much difference between a normal and an Alzheimer patient. This is a normal amyloid PET scan in a person without Alzheimer's. Remember, they got a little already though. But here in living color, we can see that beta amyloid. So, what are we looking to do in the future? Remember, I told you all this kind of stupid stuff that was way over your head about the alpha secretation, the gamma secretation, the beta secretation. Why did I bother to tell you that stuff? Well, if we could make more of alpha secretase, maybe we could make it cut that amyloid precursor protein in the right place more often, and people wouldn't develop Alzheimer's. What if we could block beta secretase or gamma secretase, and we're working at Clinical Trials of Texas on a base drug, a beta secretase inhibitor, then maybe it wouldn't cut it in the wrong place, wouldn't glom up. What if we could increase the clearance of this amyloid? And we do that by making antibodies to the amyloid. You've probably heard of that, monoclonal antibodies. It gloms on, and then hopefully your body will get rid of it. What about if we could produce a vaccine against beta amyloid accumulation? Then we could get rid of more of it. What about tau? What if we could get rid of it? And what if we could do something about other things? And some of the new areas of research include a decrease in inflammation. You've probably read a lot about that. See, what happens when this beta amyloid gets there is it causes inflammation. And we think it's that inflammation, just like your knee gets inflamed if you hurt it. That inflammation is what causes the death of tissues. Lower cholesterol. There's some research that shows if you can get the insulin under control in the brain, like decreasing diabetes, you might be able to do some good. I don't expect you to read this, but this is some of the government-sponsored testing that's going on. There's a study called API and Diane and A4 and Tomorrow Test. These are all studies to see what we can do in the future about this disease. How can you help? The government spends on heart disease $5 billion per year on research. The government spends on cancer approximately $5 billion a year on government-sponsored research. The government spends on AIDS research $3 billion per year. Until this year, do you know what the government spends on Alzheimer's? $1.5 billion a year. They spend 10 times more on other diseases, which thank God they're doing. The deaths are going down. But Alzheimer's disease, remember, is going to triple in the next few years. And so private philanthropy becomes important as well. The government, by the way, just this year doubled the amount on Alzheimer's research from $0.5 to $1 billion a year. Supports your local and national Alzheimer's disease because they can be advocates, as can AARP and others. That's one of the problems. We don't have enough advocates. Donald Trump's father suffers from Alzheimer's disease. There's hope that maybe that will spur something. Volunteer whenever you can, if you have the time. Encourage participation in appropriate studies. By the way, that's the only chance we got. You saw what happens with Aricept, Namenda, and the other drugs. They slow it down a little bit, but the only real chance is to be in a trial trying something that may ultimately help. I want to close with this. It's a poem I found when I was preparing for this talk. It was written by an Alzheimer patient's husband named Haskell, whose wife had developed the disease. It's called I Still Remember. I still remember June to December. It seems so long ago. June was the month for laughter. December, the cold wind blows. We were still young, with love all around us, shielding us from the cold. June seemed to last forever. December was put on hold. But time passes swiftly, constantly changing, not always for the good. It was the month of June, but December would come too soon. I feel the cold wind blow, starting to blow now, turning the green to gray. June has just slipped away, and December is here to stay. Although it's December, we must remember life will go on some way. All we can do is to be hopeful that June will return someday. I hope that will hopefully give you hope to not stop hoping for a cure in the future, not stop loving, not stop all the wonderful memories. And for heaven's sakes, take stock and believe in yourself. Don't concentrate on the disease. Concentrate on the memories and what we can do in the future. Thank you very much.
Thank you.